Peri-intubation hypotension occurs in 25 to 41% of patients, so what can we do about it? What's up, you guys? It's your ER pharmacist, Love Pharma. We're back with our RSI series. Today we're talking peri-intubation hypotension, which is classically a controversial topic, and we've done a lot of studies to try and figure out how we can prevent this. So let's get into it. So what causes peri-intubation hypotension? So there's a number of factors. One can be vasodilation from our induction agents. It can also be from decreased venous return from positive pressure ventilation, and then just overall reduced sympathetic drive, especially in our critically ill patients. So understanding what causes it is going to help us with our prevention strategies. So there are three main things that we have looked into pretty extensively to figure out if it helps peri-intubation hypotension. So number one is induction agent, number two is vasopressor use, and then number three is fluid boluses. Starting with induction agents, the 2025 ACEP guidelines recommend ketamine or etomidate for induction in high-risk patients to reduce peri-intubation hypotension. So they specifically recommend avoiding propofol, midazolam, and fentanyl in high-risk patients because they are more likely to cause peri-intubation hypotension. The debate between ketamine and etomidate goes on. You can see my other posts on that for more information. Moving on to vasopressor use. So we have a huge meta-analysis that came out in 2025 that showed that push dose pressors increase the patient's MAP, but they don't necessarily correlate to clinical outcomes. Now, a number of limitations with that meta-analysis in regards to emergency medicine patients. Most of those patients were surgical patients, most were not critically ill. But we do have a couple of studies like the INTUBE study that didn't indicate any clinical benefit from push dose vasopressors. So at this point, not a lot of data to support prophylactic use of vasopressors. Next up is fluid boluses. So fluid boluses, same thing. We've looked into this. The PREPARE and PREPARE-2 trials showed that a 500 ml bolus of crystalloid did not reduce cardiovascular collapse surrounding intubation. Now, again, limitation as far as emergency medicine patients. These were ICU patients who had already been aggressively fluid resuscitated, so may not apply as much to our emergency medicine patients who may be coming in dry. All right. Bottom line, choose either etomidate or ketamine as your induction agent. If you're worried about this, avoid propofol. Vasopressors and fluid boluses at this point really lack that evidence-based medicine to use them prophylactically. However, if hypotension does occur, it is appropriate to treat it, of course, but we want to avoid that prophylactically. All right, I know this is controversial, so I hope I don't stir up the internet again, but that's what I got for you guys. Come back for more in our RSI series where we're talking about post-intubation sedation and analgesia.